Coming to the second case for today's telemedicine presentation. So we have labeled it as a rare case of hypertension in a young girl. So our patient, she was a 19-year-old girl who was referred to us for suspected left paraganglioma. Her symptoms started in August 2021 with complaints of headache, and that was associated with blurred vision. And an ophthalmologist had seen her initially and diagnosed to have papilledema. So she was referred to a neurologist who did an MRI and an MR venogram in her and found that they were all normal. And because of that, they were thinking of idiopathic intracranial hypertension. They planned for an LP. While planning for an LP, for the first time, they detected something that was high BP. So the BP for the first time, in spite of this headache symptom, was checked at that time only. So because it was detected in a 19-year-old girl, she was worked up for secondary hypertension. So they had sent plasma metanephrines, and the report was awaited at the time when she was referred to us. Meanwhile, she had the outside echo report of mild concentric LVH, and then outside ultrasound abdomen along with renal artery Doppler was showing bilateral altered renal echo texture, a simple left ovarian cyst, and the normal renal arteries. And they had done an MRI abdomen there, which was showing a non-enhancing, well-defined paravertebral lesion of 3.9 into 1.4 into 2.8 centimeter, which was adjacent to the left kidney. And it was hypointense in T1 and also in T2 weighted images, and both adrenals reported as normal. So we have highlighted this hypointensity in T1 and T1 weighted images is it's of significance when we come to the further part of the presentation. So on inquiring, she was still having headache when we inquired. There was one history of palpitation in the previous 2 months. There was no history of any body weight change or hirsutism or skin hyperpigmentation or any paroxysmal events or chest pain or dyspnea on exertion. No history of fever, cough, or joint pains. There was no past medical illness in her. She was having regular menstrual cycles. In family, her father had coronary artery disease and had a percutaneous coronary intervention at the age of 35 years. On examination, the pulse rate was 92 and all peripheral pulses were equally palpable. There was no radiofemoral delay. The BP in all the 4 limbs were almost similar. It was 160 to 170 to 180 over 110 millimeters of mercury. No goiter, no striae, no hyperpigmentation, no neurocutaneous markers. CVS examination was normal, abdomen was normal, no organomegaly was there, and no renal bruit. Chest was normal. CNS, except for the fundus findings, no focal neurological deficits were there. Fundus was having grade 4 hypertensive retinopathy and papilledema, which was confirmed by ophthalmic evaluation at our center also. Coming to the lab investigations, the urine routine was normal. The routine hemogram was normal. CRP normal LFT. When coming to the renal function, her creatinine was 0.96. In our lab, the upper limit is 0.9. So she was having mildly deranged renal function, and normal calcium phosphorus thyroid function, normal ESR, normal LDH. The electrolytes, sodium was normal, but potassium, the first value was 3. On repeat testing, the value was found to be similar to have a hypokalemia. So seeing this hypokalemia in this background of young girl having hypertension, we worked up more into the hypokalemia with the urine potassium and creatinine values. So the report we got was the urine potassium creatinine ratio was found to be elevated at 25.5 milliequivalents per gram. And even though the 24-hour urine potassium was borderline normal. So she was having she was losing potassium in urine. Meanwhile, as initially we were suspecting this paraganglioma, we went into the imaging to look into paraganglioma, atypical ones in the head and neck region and chest also. So we went for a CECT chest with abdominal cuts and ultrasound of the neck. The CECT was showing bilateral hilar lymph nodes. The largest was 8 into 10 millimeter. And there were a few hypo-enhancing conglomerate masses seen in the retroperitoneal region, in the left lower para-aortic region, at the level of the lower pole of left kidney. The largest one was 2.9 into 1.9 centimeter, seen separate from the left adrenal, and both adrenal glands were unremarkable. So the differential diagnosis given by the radiologist were a typical paraganglioma or lymphoma. The ultrasound neck was showing enlarged left level 4 lymph nodes with preserved fatty hilum. Meanwhile, the outside lab, when they had already sent the plasma metanephrine before she came here, that report came by that time. It came as normal. So we had the discussion of the imaging with our radiologist. So the point against the paraganglioma was that as I mentioned earlier, the outside MRI, there was T2 hypointensity in the T2 weighted images, and this point was against paraganglioma. And also the contrast enhanced CT is showing multiple lymph node like structures. So it was against paraganglioma, and it was we have discussion among ourselves, and our concern was, could it be lymphoma or metastasis? We had discussion with our pulmonologist also, and they opined that there was a subcarinal region lesion which was large enough, and they could attempt an endobronchial ultrasound guided FNSE from that. Meanwhile, the investigations which we are continuing here, the reports were coming in. The plasma metanephrine and normetanephrine we did here, the report came as normal. And since she was having hypokalemia, after correcting that to normalcy, we had already sent the aldosterone and direct renin concentration. This report from the Newburgh lab had come by that time. Aldosterone and direct renin concentration both were elevated. So we are having a hyperreninemic hyperaldosteronism. Meanwhile, the AON-DST value came as negative. So we are having a young girl hypertensive who is having hyperenemic hyperaldosteronism, and also could be having lymphoma or metastasis which need to be evaluated. So our provisional diagnosis at this point of time were disseminated lymph node disease and hyperenemic hyperaldosteronism related systemic hypertension. Already on prazosin and nicardipine, both were started from outside, and we based on the BP we had titrated the prazosin dose to 10 milligram twice daily and nicardipine to 30 milligram twice daily, and we had started a spironolactone low dose after we had sent the sample for the aldosterone and renin. And here also we did the echo, and it was showing concentric LVH with grade 1 diastolic dysfunction. We did the renal artery Doppler here again because we are having this hyperenemic hyperaldosteronism. We had wanted to doubly roll out renal artery stenosis, and bilateral main renal arteries were showing normal Doppler parameters. So the discussion was that for the next imaging, whether to go for MIBG or PET imaging, and the decision was taken for a PET scan because we have a situation of lymphoma versus metastasis, and with very low probability of paraganglioma. So we proceeded with PET imaging, and the PET imaging, the advantage of that is that we could get the area which has maximum uptake, and that could be the area if we attempt for a tissue sampling from that, it could yield more result, better result. And also another discussion was whether to go for FDG PET or Dotanov PET, and we decided to go with FDG PET because the more possibility was for lymphoma and metastasis rather than any other possibilities. So we went for the FDG PET imaging. So it was showing this is the PET finding, that is abnormal FDG uptake in the left supraclavicular right paratracheal. Yes. So just one thing is that the maximum uptake in the PET was in the subcarinal region, and the lesion, that's the hypotenuse lesion, soft tissue lesion, adjacent to the left adrenal gland was 1.6 into 1.5 centimeter, closely abutting the lateral limb and likely node. So we can see this is the lesion, and this is the lateral limb of the left adrenal gland, and we can see the lesion coming near the renal artery at a different level. At a further lower level, we can see the image more and in more fullness. And we are proceeding with the workup for the disseminated lymphadenitis. So the serum ACE level was normal, while MANTO came as strongly positive with 29 millimeters. So we proceeded with the endoscopic bronchial ultrasound guided procedure from the subcarinal lymph node. So the smear from that was negative for AFB. The needle wash gene export for Mycobacterium tuberculosis was not detected. The FNAC was posicellular with scattered lymphocytes, but the cell block of the same showed granulomatous lymphadenitis. A better image of the granulomatous lymphadenitis comes in the lymph node biopsy, and the AFB culture was showing no growth after 2 weeks of incubation. While the histopathology from the left level 4 lymph node biopsy, this is the 4 times view, and we can see the islands of granulomatous areas. This is scattered all over. In between, we can see the hyaline. A magnified view, 10x view, is showing this granulomatous areas with indispersed hyalinization, and the further zoomed in view that is showing, this is one granuloma. So this is a granulomatous lymphadenitis. It's granulomatous lymphadenitis because why a granuloma is we can see the peripherally arranged epithelioid cells, and we can see the foamy macrophages, and we have the lymphoid cells in around that. So this arrangement of the lymphoid cells around cuffing the So in view of the disseminated TB picture, we started the patient on antituberculous therapy with rifampicin, isoniazid, ethambutol, and pyrazinamide, and we continued the antihypertensives. We were planning for a DTPA imaging because of the secondary hyperaldosteronism. We had to see for the renal arteries, renal artery. And we had actually planned for a proper losartan DTPA, but nuclear medicine actually did not do a losartan DTPA, and it was reported negative with prompt and adequate perfusion of both kidneys. While we also did a DMSA renal cortical scintigraphy because renal cortical scars can cause hyperendemic hyperaldosteronism, and it was not showing any cortical scars. There was mildly reduced cortical tracer distribution in bilateral kidneys. On the follow-up visit after 1 week, her BP was 160/100, and the antihypertensives were adjusted. And after follow-up after 1 month, further adjustment was done. After 3 months of starting antituberculous therapy, pyrazinamide was stopped. At that time, her creatinine was 1.23. And we have the follow-up FDG PET CT, which was done 4 months after starting ATT. By that time, the FDG uptake was considerably reduced, and the size also considerably reduced. We can see this was the pre-treatment FDG showing that lesion which we showed you earlier. And here we can see that the uptake has considerably, actually no uptake is there, while the size also has reduced. This is just a just for the comparison of the distribution of the. This is a fused PET imaging coming down. This is from the mediastinum.
Yeah, I think you can go ahead, move fast. Timing now.
Yeah.
Yeah.
Yes, okay.
Fused images, CD for the fused images.
So after 9 months of antituberculous therapy, the BP was 120/90. The weight had increased from 48 to 50 kg. There was good PET CT response. The ATT was stopped. The creatinine at that time was 1.3. So the final diagnosis would become disseminated tuberculous lymphadenitis, hyperendemic hyperaldosteronism secondary to pressure effect on renal vessel, systemic hypertension secondary to hyperaldosteronism, and renal failure secondary to accelerated systemic hypertension.